Anybody who doesn't know me, I'm Rob Little, and I'm going to be talking today about treatment of pediatric migraine. And for any of you who have been around for a while, you've probably heard me give some version of this talk, but it is something that I think is worth repeating because it does change over time. Although a few of these slides may be recognizable to people who have heard me in the past, there are a lot of new slides because things are changing. And for today, I'd like to focus primarily on treatment of migraine in the ED and inpatient settings, primarily because that's where some of the newest stuff is going on. I will briefly touch on outpatient treatment, but really want to focus on that. And I think even for some of the elements here that are ones that perhaps those of us who have been doing this for a while are aware of and things that maybe you've heard before, I think it's always worthwhile to go back and review some of the evidence behind all of this and try to think about why are we doing the things that we're doing in our headache pathway. I don't think I have a slide on this, but I don't have any disclosures relevant to this talk. So who cares? Why do we care about headache? Well, I think I'm probably preaching to the choir here, but as you're well aware, headaches are very common in children. There are epidemiology studies going back all the way to the 1960s, which have shown that it's a common occurrence in children. And in fact, if you go out into the community and you ask a bunch of people, have you had a headache in the last 30 days? And you leave it intentionally vague in that way. If you get a group of about 7-year-olds, about a third to a half have had a headache within the last 30 days. During adolescence, that number rises to about 75, 80%. So headache is very common. It's something that whether you like it or not, you're going to see very frequently in clinical practice. And specifically speaking about migraine, migraine is the most common condition, most common primary headache disorder that we'll see in a pediatric clinic. And it's very common in children and adolescents. The mean age of onset is about 8 years of age in boys, about 11 years of age in girls. Most people who have migraine have onset prior to 18 years of age. So it really is a pediatric condition. The prevalence does vary by age. I'm still a little bit surprised nowadays how often I hear from even from referring providers that, well, this kid's too young to have migraine. There's no such thing as too young to have migraine. There's no age cutoff for that. It is admittedly less common in younger children, about 3% age 3 to 7 years. That rises to around 11% age 7 to 11 years. And these numbers vary depending on what study you look at, but in the adolescent population, rises to somewhere between 20 or a little above 20%. Now, migraine's not always a lifelong condition. So if you look at incidence, or I should say prevalence in adults, it's a little bit lower. And so it is something that certainly persists into adulthood, can be a problem in adults, but is something that very, very commonly has onset during childhood and adolescence. And it is something that causes significant disability. Migraine may not be life-threatening, but it does cause significant disability. It causes diminished school functioning. In fact, if you look at measures of quality of life for children, children with chronic migraine have a diminishment of quality of life, which is comparable to a number of other chronic diseases, including things like asthma, epilepsy, diabetes, a lot of other things. So just because it's not something that's going to cause permanent damage doesn't mean that it's not something that can have a significant negative impact on quality of life. And migraine results in an estimated cost of about $29 billion per year. That's in the United States alone. That's actually from a study that's now a few years old. I haven't seen a newer one recently, but that includes costs, both direct costs, things like cost of coming to the clinic or coming to the ED, cost of medication, as well as indirect costs of lost productivity of at work and that sort of thing. And so that number probably has gone up since that study was done. I doubt if it's gone down. So it is a significant condition, but it is a treatable condition. And so it is something that we can have an impact on these things and improve outcomes. And I apologize, this is a little bit of a busy slide, but I like putting this in here because this is from the Global Impact of Disease Burden published through the World Health Organization, showing leading causes for disability for various conditions. And so looking at cumulative numbers of days lost to work or school worldwide. And if you look at the age group of 10 to 24 years of age, headache disorders in the most recent one, which is 2019, has risen to the second most disabling condition that we have. So it's very common, it's very disabling, it's something that we will see a lot. But again, it's something that we can intervene and improve. I'm sure all of you are aware of the diagnosis of migraine. I'm not going to read this slide to you, but I just wanted to point out that migraine is a clinical diagnosis. The International Headache Society has published the International Classification of Headache Disorders, which is currently in its 3rd edition. And so if people fit this criteria and they have a normal neurologic exam and no other red flags, then they can be appropriately diagnosed with migraine. No other testing is necessary in those situations. And migraine can happen either with or without aura. Again, I'm not going to read this slide to you. I'm sure you're all very well aware of typical characteristics of the aura. I would just point out that in the 3rd edition of the International Classification of Headache Disorders, they did reorganize the aura slightly. So if you're used to some of the older versions of the ICHD, it has changed slightly in the most recent edition, mainly in terms of how they group them and characterize them. And for anyone here who's more familiar with adult medicine, I would point out that in pediatric migraine, there are a few differences. Children and adolescents can have bilateral headaches. In adults, it has to be unilateral at least some of the time. Children and adolescents can have exclusively bilateral headaches, and that can still be compatible with migraine. Migraine headaches are often shorter in duration. In adults, it's 4 to 72 hours. In pediatrics, it's 2 to 72 hours, although there are people who advocate that that number should be even less than 2 hours. There's some people who feel that even an hour is sufficient time in pediatric migraine. And because children may have difficulty communicating all of their symptoms, it makes a clinical diagnosis challenging, especially at a younger age. But some of the associated symptoms can be inferred from behavior. So for example, if a child wants to go lay down and turn off all the lights and lay down in a dark room, even if they can't tell you that they have photophobia, you can assume that they do in that circumstance. And as I mentioned before, migraine is the most common primary headache disorder that comes into clinic. Tension type headache is very common in the pediatric population, but it's often mild, does not always come to medical attention. And so because migraine is what we see a lot, it's something that has been studied more. And so a lot of the data that I'm going to be talking about applies to pediatric migraine. And our headache pathway comes primarily from optimal treatment of migraine. So that's not to say that other types of headaches don't exist, but that's where most of the data that we have comes from. And that's what we see most of the time when we're talking about primary headache disorders. So as I mentioned, I'm going to be focusing mainly on ED and inpatient treatment, but I want to emphasize before we do that, that it is important if you see somebody in clinic with migraine to provide a good outpatient abortive treatment plan. If you do that, you can minimize the number of ED visits. Ideally, we wouldn't have patients coming into the ED or getting admitted for headache. Realistically, we're never going to be able to completely eliminate that, but with a good outpatient regimen, we can at least minimize that. And I don't really have time to go over all of the outpatient practice guidelines, but the American Academy of Neurology has published practice guidelines for both abortive and preventative pharmacologic treatments of pediatric migraine. So anybody who wants to learn a little bit more about that, that's readily available. But to very briefly summarize the practice guidelines, NSAIDs, specifically ibuprofen, but also sometimes naproxen, are considered first-line treatment for migraine in the pediatric population. There are 4 triptans: sumatriptan, rizatriptan, zolmitriptan, and almotriptan that can be used either instead of or in addition to the NSAIDs. And nausea and vomiting is very common. That can be a very prominent feature of migraine, and so always consider an antiemetic. The bulk of the evidence for outpatient treatment of pediatric migraine is with these medications. So that's not to say that's the only thing that we use, but that's where we have most of the evidence, and that's usually where we start with. If that doesn't work, there are a few other options for which there is much less data available. Other NSAIDs, ketorolac is usually given IV, as we will talk about in just a minute. Diclofenac is something for which we don't have as much evidence, but it's a possibility. Acetaminophen and aspirin are commonly used, though, to be fair, not a lot of prospective studies in migraine. Butalbital-containing combination meds are ones that we don't use as often anymore, but are still a possibility if all else fails. There are some newer meds that are not yet FDA approved in the pediatric population, but there are ongoing phase 3 clinical trials. So hopefully we'll get more information soon, and possibly FDA approval soon for some of those newer medications. And then when I give this talk again in another year or two, I'll be able to talk about those in a lot more detail. And then again, don't really have time to talk about preventative treatment in great detail, but I do want to emphasize that it is important to consider. And again, there are AAN practice guidelines regarding this. And so when do we consider preventative treatment? Well, if the headache frequency is high, a baseline frequency of once a week predicts progression to chronic migraine. So if it's at least once a week, we at least consider preventative treatment. If disability is high, we have validated measures of disability. The one that we use is the PEDS-MIDAS, the Pediatric Migraine Disability Score. If that is high, something to consider. And then sometimes if maybe the frequency or disability isn't all that high, but whatever abortive treatment we have, we're not able to adequately control the headaches. In any of those in any of those situations, we would at least consider preventative treatment. So when you see them in clinic, always consider that. Consider prevention if appropriate. Always provide them with a good acute treatment plan. But I do want to mention with the acute treatment plan to make sure that you avoid medication overuse headache. Again, I'm not going to read this whole slide to you, but there are diagnostic criteria for it. But bottom line, if people are overusing abortive medications, and exactly how many days per month you have to use it depends on the medication. The risk is highest for butalbital-containing meds, and for opioids, it's lowest for NSAIDs. It's intermediate for triptans. But if they're regularly overusing medications, then that can cause a problem. That can cause worsening of headaches, and then that can be more difficult to treat. So always make sure that you provide them with a good acute treatment plan, but also make sure that you're avoiding medication overuse. And then I have this slide on here. I've had this slide on here for a very, very long time whenever I've given talks about headache, because I think it's something that's important to talk about. It's getting better, and there are a lot of people now who are like, we don't need to hear this. We know, don't do opioids. Sure, fine, whatever. But I would point out that even though everybody says that they don't prescribe opioids anymore, certainly not for headaches, certainly not in the pediatric population, there is evidence to suggest otherwise. There are studies that have been done. The most recent study that I'm aware of was actually done in Canada a couple years ago, but there have been ones done in the US which have shown similar results. But that most recent one showed that in the pediatric population, about 20 to 25% of people with a diagnosis of migraine have been prescribed an opioid. So even though everybody says that they don't do it anymore, a significant number still are. So with that in mind, keep in mind that there is no evidence demonstrating efficacy of opioids in migraine. It hasn't really been studied for migraine, so there's no clear evidence that it's better or even equivalent to some of the other things that we do. You're all aware of the short-term and long-term physiologic consequences of opioids. We know that it has the highest risk for medication overuse headache and can lead to chronic migraine and chronic daily headaches. So apologies to everybody who says, I've never done this and I never will do that. Good for you, but I still feel that it's important for me to point out that it's still something that nobody should be doing. So I'll get off my soapbox now and go on with the rest of the talk, but don't prescribe opioids for migraine. This is the current headache pathway that we have for the emergency department and inpatient. And It's a busy slide, and I apologize. If anybody wants a better copy of this, I'm happy to provide you with a copy of it. But I point this out because it's both good and bad that it's gotten a little bit more complicated. So this kind of central part here, it used to be the entire pathway, and we will go over all of these elements. But now we have some other options. There are some other things that are available. And it used to be, again, very linear. We had step one, step two, step three, and we went through those in order, and we kept going until the headache was gone. Now we have some alternatives, some other things that we can do. We don't have great evidence as to which of these options is best. And so it's not as linear as it used to be, but I think the advantage is that we have more options, we have more tools available to treat migraine, both in the emergency department and in the inpatient setting. So let's go through all of these elements. So you've provided somebody with an appropriate outpatient regimen. You've done the best you can to manage their headaches, but despite everybody's best efforts, they have a headache which just isn't going away. Status migrainosus, by definition, is a headache that's been going on or a migraine, I should say, that's been going on for more than 72 hours. Now, we know that after about 24 hours, none of the oral medications work as well. So we don't need to necessarily wait the full 72 hours. But we do know that by the time it's been over 24 hours, we can still try some things at home, but nothing's likely to be very effective. So at that point, sometimes the best that we can do is to have them come in and receive IV medications. And as was on the headache pathway, the first line treatment usually consists of a combination of IV medications. Now, our headache pathway is similar to other headache pathways and published pathways. They may not be identical, but a lot of them start with a combination of meds, and it's usually something along the lines of ketorolac and prochlorperazine and diphenhydramine. So why do we use those three? What's up with that? So for ketorolac, it has been specifically studied, admittedly less so in the pediatric population, but there is at least adult migraine data that it is effective for treatment of migraine and specifically for treatment of status migrainosus. And again, it's usually used in combination with other meds, the so-called migraine cocktail. These combinations have not been formally studied. There's not really any prospective data out there that looks at ketorolac alone versus ketorolac plus prochlorperazine, for example, or ketorolac plus some other medication. So although we have data for ketorolac, we don't know that the combinations are necessarily better. We still do it, but it may or may not be better in combination. But it is something that's available for IV administration, so it can work more quickly. And in the case of people who have a lot of nausea and vomiting, if they're not able to keep down any meds, is something that can be effective. Antiemetics and particularly the anti-dopamine agents, the dopamine antagonists are ones that can be specifically useful for the headache itself. And as I point out here, definitive data in pediatric migraine are lacking, but it has been something that has been studied in adults, and prochlorperazine has been studied by itself and shown to be effective not just for prevention of nausea, but for the headache as well. And so prochlorperazine has a little bit more evidence, and that's the reason why we use that, is that it may be more effective specifically for headache, not just for the nausea itself. But other dopamine antagonists, including metoclopramide, promethazine, droperidol, have been studied and can also be effective, though the evidence on all of those is less than what we have for prochlorperazine. Though I would point out with metoclopramide, there was a retrospective study that was done fairly recently, specifically in pediatric migraine, that looked at these antiemetics. And again, it was a retrospective case series, so take that for what it's worth, but it did show that metoclopramide was associated with a higher rate of bounce back to the ER, so repeat visit to the ER within 30 days compared to promethazine or prochlorperazine. So I don't know that a single retrospective study constitutes any sort of proof positive with that, but again, for what it's worth, that one retrospective study did show that. And then ondansetron is something that has fewer side effects, can be better tolerated. However, it helps only for the nausea. It has not been shown to be effective at all for the headache part of migraine. But if they're not able to take some of these other medicines, or if they're not well tolerated, then ondansetron is certainly a reasonable alternative and something that we use on an outpatient basis very frequently. Diphenhydramine is a little bit controversial in that we don't really have a lot of evidence that it is effective for headaches. If it is effective for headaches, it may be because there are some central serotonergic effects, and presumably that may be something that can help for migraine, but again, that's unproven. We know that sleep is helpful for migraine. There are some people that feel that diphenhydramine is helpful only because it's sedating and it helps you go to sleep. And if you sleep, then that helps with your headache. So, okay, that does make some sense. But again, it's not really definitively proven. There are no good studies done on that. It's done sometimes to prevent other side effects. So I mentioned side effects with some of the dopamine antagonists that they can cause dystonic reactions. This can help to prevent that. So it can be helpful for that. So of all of the elements of the headache pathway that we have, this is the one for which we have the least evidence. But it may or may not be helpful. It probably isn't doing a lot of harm. So it's on the pathway. Many centers with published headache pathways use this, but it is probably the weakest from an evidence-based standpoint of all the meds that we have. So you get that combination and the headache goes away. Wonderful. But what if it doesn't? If that doesn't work, IV valproate, a loading dose of 20 milligrams per kilogram of IV valproate, has been shown to be effective. If it is effective, it can be continued. If the headache is improved but not gone and they're going to need to be admitted, then that can be continued IV, or it can be continued PO. We often don't do that for an extended period of time just because of side effects with long-term use of valproate, but it is something that can be used more for short-term prevention. IV magnesium can also be helpful. And in the original version of our pathway, first-line treatment was the combination of ketorolac, prochlorperazine, and diphenhydramine. Second line was valproate. Third line was magnesium. If all of those failed, then we go to dihydroergotamine, or DHE. And with some of the other options, which we'll talk about on the pathway, it's still the case that if all else fails, DHE is kind of our final step. So dihydroergotamine, DHE, is primarily a 5-HT1B1D receptor agonist. Now, all of the triptans have that exact same mechanism of action. All the triptans are also 5-HT1B1D receptor agonists. The problem with the triptans, as I mentioned before, after the headache has been going on for a while, in the case of triptans, even for a few hours, they're much less effective, probably because the 5-HT1B1D receptors, in addition to the 1B receptors being found on blood vessels and can have, and so can cause vasoconstriction with that, also present at the trigeminal ganglion. And so it is something that is peripherally acting. By the time the headache has been going on longer and you have central sensitization, it's being primarily driven by central mechanisms, probably a peripheral acting agent is going to be less effective. DHE, however, also is a receptor agonist for the 5-HT1E1F receptors, and that is present, among other places, in the trigeminal nucleus caudalis, and so can act centrally, and so that probably explains why DHE can work when there's been a delay in headache. It can work in cases of status migrainosus, whereas the triptans do not. And so it's something that's given IV on our pathway. It's given every 8 hours. The most common side effect that we see with DHE is nausea, and so we always pre-medicate with an antiemetic and diphenhydramine. And then we have a titration schedule. We titrate up to a max dose of 1 milligram. And then once we get up to 1 milligram, give it at least 3 doses to see how well it's working. If there are any unacceptable side effects on a higher dose, you can come down to a lower dose and hold at that previous dose. And then typically, once the headache is resolved, we give one additional dose. The downside with the DHE is that it often does take several doses. There is a retrospective case studies published out of the University of Cincinnati by Mariel Kabush and colleagues, which showed that in their protocol, which is very similar to the one I just showed you, they are about 75 to 80% successful in getting rid of headaches. However, the mean number of doses of DHE that it takes to do that is about 5 to 6. So that's a couple of days worth at a dose of 1 milligram. And so if it takes you a little while to get up to that dose and then you got to give it for a couple more days, that's something that can prolong the length of stay. And so that's one of the reasons why it's something that we do only after other things have failed. But if all else fails, it is something that can be very effective. So what else do we have now? Propofol is now something that we can give in the ED. Propofol is a gamma aminobutyric acid receptor agonist. It may also inhibit NMDA receptors, and that can be helpful for migraine, which I will talk about in just a minute with another agent. There is limited evidence in pediatric migraine. I have referenced below there two retrospective studies from the same institution looking at propofol specifically in pediatric migraine. In adults, there's a little bit more data. And with all of these protocols, it's sub-anesthetic doses given every 5 minutes times 5. Some of the protocols will give a few more than 5 doses, but our protocol, it's every 5 minutes for 5 doses or until the headache is resolved. There are no comparative studies showing that propofol is clearly more effective than any of the other agents. One of the adult studies looking at propofol in the ED did show that on average, people who got propofol had a shorter length of time in the emergency department. So there is possibly some evidence that it can shorten the ED stay. However, it is a little bit more labor intensive because you've got to give a bolus every 5 minutes and you have to have them monitored closely during that time. So usually it means that a staff member, it can be a nurse, but a staff member needs to be in the room with the patient for that period of time. And so for that reason, it sometimes is something that isn't always readily available if things are very busy in the ED and if there isn't somebody available to do that. But something which is certainly a reasonable alternative and something which has been shown, particularly in adults, to be pretty effective and possibly a more efficient way of getting them out. And so the other thing that we have are nerve blocks. This is a little drawing that I like. It does show a specific brand of catheter that is used for an SPG block. This is not to endorse that specific brand. There are several of them that are available. But if you use any of these catheters and you go along the middle nasal turbinate, at the very posterior part of that is the sphenoethmoid recess. If the patient is supine and you administer something like, say, lidocaine, that will be right over the sphenopalatine ganglion and will get absorbed in the sphenopalatine ganglion. And so is a way that you can do a sphenopalatine ganglion block. And so it's something that's fairly easy to do. Although it does involve inserting a catheter into the nose, it does not involve any needles, and so usually fairly well tolerated. The other type of nerve block that we commonly do is an occipital nerve block, and this drawing is actually a very old one. This is from an early edition of Wolf's headache textbook. I don't know why I keep this in here. I should probably have a more updated picture, but there's something about it that I like. But the bottom line is that If you draw a line from the occipital tuberance to the posterior part of the mastoid process, about a third of the way along that line is the root of the greater occipital nerve. And so you can inject something like commonly bupivacaine, and that'll get absorbed in there. If you want to go along about 2/3 of the way along that line, you can also target the lesser occipital nerve. We don't do that inferior injection very much anymore, but that was originally described as well. The thing about the nerve blocks is that we really don't have a lot of evidence for them. They've been done for a very, very long time. The earliest reference that I could find to a nerve block in the literature is in 1908. So this is something that has been done literally for over 100 years. And so possibly because of that, we don't have a lot of good prospective data. There are no randomized controlled trials at any age evaluating the efficacy of nerve blocks. There have been some retrospective studies and some retrospective studies specifically in the pediatric population looking at efficacy of nerve blocks. But again, those are all retrospective case series. But there have been some of those done, and it is something that is very commonly done. The pediatric section of the American Headache Society sent out a survey a few years ago looking at pediatric headache experts and just asking how often do you do nerve blocks? And about 80% of people in that survey said that they do regularly do nerve blocks. So it is something that is very commonly done. It seems to work, but for what it's worth, there aren't any good prospective trials that have clearly demonstrated efficacy. There are people in the emergency department who are trained to do SPG blocks, so that is something that we can sometimes get done in the emergency department. However, that's a little bit variable because not everyone in the ED is trained for that. So it is a little bit variable depending on who's there at the time, but that is something that can be done in the emergency department. We can do nerve blocks, both SPG and occipital nerve blocks in the clinic. And so that is something that we can sometimes do as a way of avoiding the ED or inpatient. But those are certainly possibilities. And then probably the newest thing that we have is ketamine. Ketamine is an NMDA receptor antagonist, and it's primarily used as an anesthetic. It has been used more recently for various types of chronic pain. It has been used for medically refractory depression. How it works for migraine is not clear. NMDA receptor antagonism can lead to decrease in glutamate release, and so it may be inhibition of glutamate that is the reason why it works for migraine. Also with blocking NMDA receptors, that seems to have an impact on cortical spreading depression. So that may also be a mechanism of action, but it's not clearly known why ketamine works specifically for migraine. But ketamine infusion has been used in adults with refractory chronic migraine and new daily persistent headache. There is a study on intranasal ketamine, and it was used in adults for migraine with prolonged aura. And I mentioned before with NMDA receptor antagonism that you can have an impact on cortical spreading depression. So presumably that's why it may work with prolonged aura. There is not as much data in the pediatric population with ketamine. There have been a couple of retrospective studies. It is something that now is used at some pediatric headache centers, and it is something that we have very recently started using here. So it is typically used at this point for patients who have been refractory to other treatments. So they've gone through that whole pathway, including DHE, and it hasn't worked. And so in those cases, we have started a ketamine infusion protocol that's done in conjunction with the pain service. And so we consult them. If there is an inpatient and they might be a good candidate for ketamine and you have any questions, feel free to contact one of us. But it's something that if you consult neurology on the inpatient side, we have the ability to do that. It's early on. I don't have exact numbers. We've done it on maybe a half dozen or so patients here. And so it's a little bit too early to know exactly how well it works. It seems like, as with everything else, it's not working 100% of the time, but there have been some patients who haven't responded to anything else and have done very well with the ketamine. So again, I think it's something that's an option. We need to do it a little bit more and possibly collect some data to know how well it's working, but is something that we now have available to us. So I'm pretty proud of the headache program here in that I feel like we do a lot of the things that are available. If you look at the literature and you look at what's out there to treat headache, we're doing most of those things. But are there any things that we're not doing that possibly we could do? The only thing that I could find in the literature, there was one study published in 2018 looking at continuous infusion of valproate. And so as I mentioned before, we typically give a loading dose, and then if it's effective, we can continue it scheduled. But this was a study looking at continuous infusion of valproate at a dose of 1 milligram per kilogram per hour. And it was specifically in pediatric migraine, did show that it can be effective, but it wasn't compared to anything else. So it was an open label study, hard to really interpret it too much. So I don't know that there's necessarily a huge rationale for that, but for what it's worth, it's out there. That's something that has been published now. And then lidocaine infusion is something that has been used in adults for a long time. There is very limited evidence in the pediatric population, but something that is used. The biggest drawback with the lidocaine is with a continuous infusion, you have to monitor their cardiac status very carefully. And so usually something that has to be done under telemetry or at least close cardiac monitoring. And so logistically is somewhat difficult to do. But there are other pediatric headache centers that do lidocaine for pediatric migraine and is something that can be helpful. Now, I mentioned before that a lot of these combination therapies, I should say, have not been really well evaluated. We have all of these elements, and I just went through all of the evidence that we have for the use of some of these specific items on the pathway, but we don't really have any evidence about, well, which combination is best, or why do we do it in the order that we do it? Is there a different order that makes sense? And so none of that has really been well studied. However, there have been 2 studies that have been done. One was done here at Phoenix Children's Hospital. The second one was done at Yale, but they showed very similar results, which was that if you implement a standardized protocol, it improves outcomes. So if you look at patients coming to the ED, for example, before and after a standardized protocol is implemented, after implementation of the protocol, hospitalization rates go down and the number of patients who are discharged with 0 headache goes up. And so even though the specific combination, the specific order is debatable, having a standardized protocol in place has been shown to be effective and is something that can improve outcomes, at least in the ED setting. So to wrap up then, although we don't have as much evidence as we would like, that's a common complaint in pediatric neurology and probably pediatrics in general. We do have several options for treatment of acute management of headache and specifically for acute management of status migrainosus. Always keep in mind that a good outpatient regimen is a starting point and you want to try to keep them out of the ED if at all possible. But when all else fails, having a systematic approach in the ED and inpatient can optimize treatment. So that's all I have. Thank you all for your attention. And if you have any questions, I'd be happy to answer them.
Hi, Rob. It's Kara Lewis. That was great. Well done. I love all the information. My question would be, I love having the systematic approach to all of this, especially in the emergency department. But a lot of times there's a variation between some people thinking it is a pathway that has to be followed, and there's others who are more algorithmic about it and picking and choosing. And then there's some families who will come in and say they want it more like just a menu where they can pick and choose. So how do you teach the emergency department providers, and how do you teach parents about what they can say and what they can say no to?
I mean, it's difficult in some ways because, again, we don't have great evidence as to what an optimal pathway looks like. And so, I think being a little bit flexible is not necessarily wrong. But at the same time, I think we do have to have a systematic approach. If we're too scattered with it, then it probably is going to be more problematic. And so I know I'm not really answering your question right now. I'm just babbling, but I think that the answer, what I would teach, what I would say is that I think we need to have a consistent approach. And so I think, going through that in a systematic fashion is the most appropriate way to do it initially. But I think we can have some individual variability, especially those repeat patients. If we have a patient who comes in and we know a certain element of the pathway does or does not work, then we can use that information. And I think that's where making exceptions to the rule is probably the most important. Is if it's something where, like, yes, every time we come in, they give us this and it never works. We always have to, go on to this next thing. Then yeah, you can skip that and go straight to whatever is working.
Thank you. And I think there's a few questions in the chat too.
Okay, let's see here.
We also have a few people with their hands raised. JBB, if you want to unmute.
Okay, Rob, excellent talk. Yeah, very good. I would say two things. One of the reasons that the systematic approach improves the results is that it prevents the folks in the emergency room from dithering about what comes next, and improves the speed with which it is carried out. The other thing I would say is that one of the real problems with headache studies is the large placebo effect that exists. And that's so with any drug you use, how you sell it is important in how well it works. Because any snake oil salesman can tell you that with any drug. So it's important to be confident in what your protocol is and sell it as though it's going to work, and you're more likely that it will under those circumstances. Thanks.
Yes, I would agree. And it is true that the placebo effect, obviously, that's comes into play with any medication and any study, but is higher in headache and higher in pediatric headache than in a lot of other areas. And so that is a challenge whenever we're trying to evaluate some of these medications.
Dr. Hopman? Oh, sorry.
Oh, yeah, sorry, go ahead.
Oh, I said Dr. Hopman is up.
Yeah, hi. Yeah, hey, Rob, that was a great talk. As a dilettante in headache myself, I actually learned an incredible deal from you. Headache, by far and away, is the indirect reason why we see patients in neurosurgery. We see, I mean, I think all my partners would attest that we see incidental MRI findings daily that really are not pathological, but those children are sent to MRI because of headache. And so I would say, at least me personally, I probably, unfortunately, and thank you for doing it, generate a lot of referrals to neurology for children with headache with incidental pineal cyst, Rathke cleft cyst, Blake pouch cyst, all these things that I think patients wish were the etiologic cause of their headache, but unfortunately are not. How can we help you in the neurosurgery clinic tee these patients up so that we're doing something while they're waiting to see one of you or your fantastic colleagues? I don't know that I can prescribe or maintain medication. Is there a handout we can generate? Are there diaries you want us to tell them to keep? A vitamin like mag or dietary restrictions, or what? How can we partner with you on this so that we're at least helping them in between when they see us and they find out the pineal cyst is not the reason for their headache, and they see one of you guys?
Yeah, no, that's a good question. And again, I was kind of focused on ED inpatient treatment. So maybe another talk that we can provide from the headache group would be more outpatient management of this. But I think a couple of things. again, starting with something as simple as an NSAID can be helpful, and, picking a triptan. In terms of preventative medication, we have a handout for vitamins and supplements, and we'd be happy to share that with anybody who wants it. And then there are some, in terms of the preventative medications on the outpatient side, in the pediatric population, we have the most evidence for amitriptyline, topiramate, and propranolol. So if it's a situation where you feel comfortable prescribing one of those, that would be a possibility. And then, yes, we have handouts in terms of keeping headache diaries and in terms of lifestyle modifications for headache triggers and managing triggers. And so that certainly is something that we can share with anybody, that if that would be helpful in your clinic, we'd be happy to help you out with that. And then I would also add, as an aside, I have my big soapbox that I get up on for opioids. The other big soapbox I get up on is unnecessary imaging, and I think the residents who work with me know that that's a big thing of mine. We have good evidence-based guidelines from the American Academy of Neurology based on multiple prospective studies that show when we do and don't need to image in the pediatric population. And so avoiding doing that imaging and avoiding having to then go see, neurosurgery for an incidental pineal cyst, I think is something that on our end is something that we need to also be very mindful of.
Thanks. I would love to get those handouts from you. And I love that last thing that you just said. May you live a long, long, prosperous life and a fantastic professional career. Thank you on behalf of neurosurgeons around the world.
Thanks. Okay, so going into the chat, is there an NSAID regimen you recommend for those who don't know much about prescription triptans? Yes. So again, according to the AAN practice guidelines, ibuprofen is the first step, and naproxen has a longer half-life, and so sometimes can be helpful for that. And so it's a little bit longer lasting, but 10 milligrams per kilogram orally is a good place to start with that. In terms of the triptans, I often use either sumatriptan or rizatriptan. Rizatriptan comes as an orally dissolvable tablet if you're not able to swallow pills. They come as 5 and 10 milligrams. There's not a clear dosing regimen for that, but usually adolescents, I'll give 10 milligrams. If they're a little bit smaller, a little bit younger, I'll give 5. And that's usually a good place to start. The triptans are vasoconstrictive agents, and so if there's anything for which you cannot give a vasoconstrictive agent, it's contraindicated, but otherwise triptans are very well tolerated. And so you can start with ibuprofen or naproxen and then add on rizatriptan. A bit off topic, but could you share what the Headache World says about the CHAMP study? I can't, because it would take another hour to go through that in great detail. The short version of it is that the results are rather controversial even to this day. And there are a lot of different opinions. There are a lot of very strong opinions on it. My very brief opinion on it is that it's one study out of a lot that we have looking at treatment of pediatric migraine. It has its pros and cons. It's not a perfect study, but I would caution anybody from drawing all of your conclusions about treatment from any one study. Is there any standard to go to for post-discharge headache management once we can get them hopefully to a 0? So first of all, we want to get them to a 0. I didn't mention that. That's a goal of treatment. We know that if you have any residual headache, your chances of recurrence within 72 hours is much higher than if you get it down to a 0. So although we're not 100% successful at that, we always shoot to get down to 0. After that, it's mainly a matter of making sure that they have a good outpatient regimen. Just like I said before, hopefully you do that to prevent them from getting in, but once they get in, make sure that they have a good outpatient regimen, make sure that they have something to go home with. And whether that's a preventative medication that you start or at least an acute treatment, they always have to go home with something. And make sure that they have a good outpatient regimen to go home with. You can sometimes give steroids. Steroids can help to prevent short-term recurrence, although that's another somewhat controversial topic. Is there a washout period between using DHE inpatient and ketamine in pediatrics? Not necessarily, no. So it's not something that's used concurrently. I believe as soon as next day they use it. And so DHE, the reason why we give it every 8 hours is it has a relatively short half-life. I don't remember off the top of my head what the half-life is exactly, but it should be out of their system fairly quickly. So by the time we consult pain team and they come in and get it set up for the next day, we've stopped the DHE, and that's usually not a problem. But certainly not within 2 weeks. I think within 24 hours. Can you talk about real-time continuous care versus episodic care that your group is pioneering with a home application? Yeah, so we have a home monitoring app that we're piloting right now. We've been doing it for a little while where we can sign people up for home monitoring. They will get texts through their phone. One of the glitches that we haven't been able to fix yet is it's the phone number that's on file in the chart, which is usually a parent's phone number, but somebody is getting a text once a week, usually on Fridays, asking them how many headaches have you had in the last week? What have you taken for your headaches? And then every Monday we get an email that has all of that information. And so it's something that we're really able to then, in those patients that we feel need to be more closely monitored, those whose headaches maybe aren't optimally controlled, we can look and then be able to send them a secure health message or even give them a call if we need to, and be able to really monitor them more closely. So it's something that's been really a very nice tool that we've been able to use to more closely monitor some of these patients and allow us to get, as you said, kind of some real-time or at least much more detailed information in between visits than we would otherwise be able to get. If anybody's more interested in that, I can tell you about it. We were kind of piloting it at first using some smaller numbers to make sure that, you know, we had everything going, but I can tell you know, tell you a little bit more about it if there are patients that you feel may be appropriate for more careful monitoring. All right, any other questions that anybody has? All right, well, thank you all again for your attention and have a nice day.
Thank you, Dr. Little.